Can you see my screen?
Yes po, Doc.
Ano nangyari? Bakit bigla naputol yung ano kanina?
Hello, in this video we're going to talk about hernia, specifically inguinal hernia. We're going to look at the signs and symptoms, the risk factors, and I guess...
Did you hear the audio?
Yes po, Doc.
Okay, good. Okay, we'll start in 2 minutes. Okay, I think we better start. We have a long morning. Good morning, everyone. And today we'll be talking about the abdominal wall, defects, anatomic defects, and some other organ systems, which you will see later on. So we'll start off with inguinal hernias, which is actually one of the this is the highlight of this lecture, where most of the questions will be coming from. So please pay close attention. So we'll be talking about the definition of hernias, epidemiology, anatomy, pathophysiology, up to the diagnosis and management of these conditions.
Hello, in this video we're going to talk about hernia, specifically inguinal hernia. We're going to look at the signs and symptoms, the risk factors, and I guess how it actually happens and how do we differentiate between the different types of inguinal hernias. So hernia itself is defined as a protrusion, bulge, or projection of an organ or part of an organ through the body wall that normally contains it. And there are different types of hernias, and it can be divided mainly into internal and external. We will mainly be talking about external hernias. Now, external hernias include inguinal hernia, which is the most common of all these, which is 80%. Then you have incisional hernia, 10%, femoral hernia, 5%, umbilical hernia, 4%, epigastric hernia, less than 1%, and then you have others. So the inguinal hernia and the femoral hernia are known together as groin hernias because they occur around the groin area. So let us actually talk about the inguinal hernia because that's what we're going to talk about mainly here because it is the most common. So what we actually see in an inguinal hernia is the intestine, which is the organ, actually bulging out or pushing out of the wall that normally contains it, which is the abdominal wall in this case. So the abdominal wall is actually comprised of, from the outside, the skin, the subcutaneous, and then you have the abdominal muscles. And there are 3 abdominal muscles here. From the outside, it's the external oblique, the internal oblique, and then you have the transverse abdominis. So again, an inguinal hernia is essentially the bulge or protrusion of an organ, this being the intestine, through the wall that normally contains it, which is the abdominal wall. So what are some signs and symptoms of someone who has an inguinal hernia? Well, obviously it depends on the severity and how much it's actually bulging out and if it's strangulated. But the signs and symptoms altogether are, obviously there's a visible lump, that's a sign, a heavy discomfort around the gut, you can have pain and aching on exertion, so maybe like lifting up something. You can experience constipation, and I guess you can also say that the lump enlarges upon coughing as a sign. So what are some risk factors for someone to develop an inguinal hernia? Well, these include a history of hernia, older age, male sex, being Caucasian, having a chronic cough, chronic constipation, I guess a weak abdominal wall, and then also smoking is a risk factor. So again, inguinal hernia is you have the bulging of the small intestine here through the abdominal wall. So let's look at this from an anterior view. So here we have the groin area. Here's the linea alba, which makes up part of the abdominal muscle, right? And then here you have the abdominal muscles. From the outside, you have the external oblique, which has been opened up, as you can see here. And then you have the internal oblique, and then below the internal oblique, you have the transversalis abdominis fascia. And here we are actually just pulling on the spermatic cord. It's been retracted. So we're pulling over it, and because we're pulling it, we can actually see below the spermatic cord, or next to it, we have important artery, which is actually a landmark. Keep note of this. And the artery is the inferior epigastric artery. And the inferior epigastric artery is an important landmark because it sort of differentiates between the different types of inguinal hernia. And we'll talk about that as we go. And then here, I guess above the penis area, you have the conjoint tendon. And it's sort of medial to the inferior epigastric artery. Now let's look at the same image. So we're looking at the muscle layers, the inferior epigastric artery and the spermatic cord. Let's look at this image, but from a different angle. Let's cut a cross-section of the body and look at it from the top. So here you have your small intestine, or intestines, and then we have the peritoneum, which actually holds all your sort of covers, is the inner lining of the abdominal cavity. And then the next layer you have the transversalis abdominis, or the fascia, and then you have the internal oblique, external oblique, and then you have the external oblique aponeurosis, and then you have the subcutaneous, and then you have the skin. So these are the layers from the inside of the abdominal wall to the outside. And then you have the spermatic cord, which originates behind the transversalis fascia. It goes down and it goes through all these layers and down to the scrotum. So it travels medially and down to the scrotum. And then medial to the spermatic cord, behind the transversalis fascia, you have the epigastric artery, which again is an important landmark, and it's medial. And then you have also the conjoint tendon here. So I hope that made sense. Just remember these layers, and remember the spermatic cord, how it travels medially, and then also the inferior epigastric artery. So let's talk about inguinal hernia. And again, what we will see is that we will see these intestines, they will actually go through, sort of bulge through these abdominal walls. So now I'm just going to draw the inguinal hernia as we saw before. And here's the intestine, which is bulging sort of through the abdominal wall, pushing against the abdominal wall. And here we have the same image of the right side of the sort of groin area. And then we have hernias, the inguinal hernias. And there are two types of inguinal hernia. We have what's known as an indirect. So an indirect inguinal hernia is the one that sort of pushes, bulges through the abdominal wall and actually goes into the scrotum. So it sort of follows the spermatic cord pathway. And then you have a direct inguinal hernia, which is just a hernia that sort of bulges through the abdominal wall and doesn't actually go down the scrotum. So what differentiates these two types of inguinal hernias, the direct and indirect, is the important landmark that we talked about, which is the inferior epigastric artery. And here we have the inferior epigastric artery. And essentially, if the inguinal hernia occurs medially to the inferior epigastric artery, it's a direct hernia. But if it begins laterally, then it's an indirect hernia. Now, talking about indirect hernia, it follows the spermatic cord pathway, because an indirect hernia actually originates from the deep inguinal ring. It goes through the deep inguinal ring and the superficial inguinal ring. And so this is obviously the same pathway, the spermatic cord, and so the intestine will actually follow this pathway, follow the spermatic cord pathway, and into the scrotum. Now, an important landmark area, important region to know, to remember for hernias, is known as the Hesselbach's triangle. And so the borders of the Hesselbach's triangle is the inguinal ligament inferiorly. You have the inferior epigastric laterally, and then you have the rectus abdominis medially. So let's look at these two types of inguinal hernias in a bit more detail. So again, you have two types of inguinal hernias. You have the indirect inguinal hernia, and you have the direct inguinal hernia. So let's begin by talking about the indirect inguinal hernia. Indirect inguinal hernia is the most common type of hernia. It's where the intestines protrude at the deep inguinal ring, and it's lateral to the inferior epigastric artery. So it starts laterally. So if we were to draw that same diagram that we drew, the cross section, and we're looking at it from the top, from a superior view, we have the layers: the peritoneum, the transversalis fascia, the internal oblique, the external oblique, and then you have the external oblique aponeurosis. And here is your deep inguinal ring, essentially a hole where the spermatic cord originates from the peritoneum. And then you have this superficial inguinal ring where the spermatic cord will exit. So I'm actually drawing the spermatic cord here in yellow, and it's not quite right. It should originate from the deep inguinal ring. And then you have the inferior epigastric artery. And remember, an indirect hernia occurs laterally to the inferior epigastric artery. And so an indirect hernia is where the intestine will go through the deep inguinal ring and then through the superficial inguinal ring and essentially bulge out. So I hope that made sense. And again, the indirect inguinal hernia occurs lateral to the inferior epigastric artery, and essentially follows the same pathway of the spermatic cord as shown. So a direct hernia is where we have a protrusion medial to the inferior epigastric artery within the Hesselbach's triangle. And remember, we learned about the Hesselbach's triangle. So Hesselbach's triangle is where direct hernias occur. And the direct hernias occur as a result of weakness in the floor of the inguinal canal. And it passes through the superficial ring only. It doesn't go through the deep and superficial. The direct inguinal hernia only goes through the superficial. And we will see how. So again, we're looking at this diagram from the top. And here I'm drawing the spermatic cord in yellow. And here we have the inferior epigastric artery. And here is your deep inguinal ring where the spermatic cord originates, right? And then here you have the superficial inguinal ring where the spermatic cord also goes through. Well, in a direct inguinal hernia, it only goes through the superficial inguinal ring. So what what we see essentially is the intestine will go through these layers, and the intestine will just go through the superficial inguinal ring, medial to the inferior epigastric, and not go in contact with the deep inguinal ring. So again, the direct inguinal hernia occurs medial to the inferior epigastric, and the indirect inguinal hernia occurs laterally to the inferior epigastric. And I hope these diagrams made sense. Thank you for watching.
Okay, so I hope you had fun with that video. As you see, inguinal hernias are better appreciated with a video rather than just with your imagination. So as we move on, okay, just a recap of what you just saw. So inguinal hernias, like your indirect and direct hernias, usually presents with pain, swelling, and discomfort in the groin area. And upon physical examination, it should reveal a bulge in the inguinal area. Now, of course, a special consideration is among the younger population, especially in children. Sometimes when a mother brings a child to you and complains of a hernia, for example, sometimes it's so difficult to illustrate and to appreciate the actual occurrence of the hernia, even if you ask the patient, if you try to make the patient cough or cry. But most of the time, no mother will be bringing his or her daughter, more commonly among the males, no? So her son, I mean, to the doctor complaining of a possible hernia when there was or there is in fact none. So we just base it on historical data and usually coming from the parents. So of course, very common are or what we should watch out for are red flags, which would indicate the beginning complications of hernias, and this includes pain, fever, changes in the bowel habits, no? Especially presenting as intestinal obstruction. Because what we fear actually when we talk of inguinal hernias are the complications, which would include incarceration, and worse is strangulation with resulting intestinal or any visceral ischemia, which will lead to a more complicated management, which would entail some form of resection. So to diagnose, a very good history and clinical examination. It's easier if the patient claims that he or she has been experiencing this kind of problem for a considerable period of time already upon seeing you. But once in a while, we see patients who come in with complications of an inguinal hernia with the occurrence of the lesion for the first time. No? So they experience the bulge for the first time, but when they see you, it's already incarcerated and with the possibility of it being strangulated. So it becomes a little more complicated. And we have to make sure that we are dealing with a hernia rather than some of the differential diagnoses, which can also present in such an acute fashion, which we will be dealing with later on. So, of course, basically, hernias are diagnosed most of the time with history and clinical examination without the use of any imaging studies. But in instances where there is doubt as to whether this is indeed a hernia, then we can resort to imaging studies, which can include an ultrasound, a CT scan, or an MRI. And hopefully, these imaging studies would help us rule out the differential diagnosis. So, history, groin mass, which protrudes with standing, And of course, it is aggravated by straining. And initially, hopefully, it is still reducible when you ask the patient to lie down, and sometimes when you ask the patient to assume the Trendelenburg position. Okay. Also, very important in the history is to look for any changes in bowel habits, no? Especially like constipation and worse obstruction with abdominal distension. Sometimes also you have to make sure that there is no LUTS, no? What we call LUTS, L-U-T-S, no? Lower urinary tract symptoms, which could include difficulty in initiating urine flow, decrease in caliber, because these are risk factors which are associated with development of hernias, no? When the patient strains, like lifting a heavy weight, chronic coughing, constipation, which would entail patients straining down to just move the bowel. These are all increasing the intra-abdominal pressure and can precipitate the occurrence of a hernia in patients who are susceptible to develop one. Of course, other symptoms are referable to compression of the nerve by the enlarging balls, no, within the sac, and can in fact also cause referred pain, which may involve the scrotum, the testicle, or the inner thigh. So sudden onset of symptoms are more concerning. Okay. If the patient has been complaining of such a bulge for a long time, but now there's severe pain and there's tenderness, erythema overlying in the overlying skin, and of course, worse is if the patient starts to develop fever, then these are the red flags that we were talking about a while ago. So very important is whether it is reducible or not. And sometimes because of a wide defect, a lot of intra-abdominal organs are coming out of the opening, so it might be challenging to reduce an incarceration in that area. So if you want to manage the incarceration by reducing it initially in the emergency department, then sometimes we have to sedate the patient, give the patient muscle relaxants, and of course, let the patient assume the Trendelenburg position. So also, again, very important is to review the systems of the patient. This is very important when we talk of management because failure to elicit some of these symptoms or to notice these symptoms or historical aspects can result in early recurrence or failure of the repair, no? And we're talking about a history of constipation, history of chronic cough, especially in elderly patients with chronic obstructive pulmonary disease, or the presence of LUTS, no? Lower urinary tract symptoms. All of this can compromise our repair and, of course, result in early recurrence. Because in hernias, when we talk of the best technique, then we talk of the technique that would result in the least recurrence. Okay?
For inguinal-related pain, some athletes will present with a frank hernia, although that's not common in a football population. Most of these patients are said to have a weakness of the posterior abdominal wall. So what we're going to do here is, again, palpate. So I'm going to find the pubic symphysis, palpate over the pubic symphysis, move laterally onto the pubic tubercle, and then palpate around the low rectus and conjoint tendon. So can you lift your head just up off the table? So that helps me locate those landmarks. So we're palpating in and around here, you drop down again, and palpating around the superficial inguinal ring. And it's useful to do that with the athlete standing up because that's a position where we might be more likely to see a hernia. So palpation there, does that reproduce something like your pain? And then we're going to do a resisted sit-up. So if you come into a sit-up type position there with your knees bent, lift your shoulders up off the bed. So lifting up, holding there, stop me pushing down. So if the athlete has pain and problems with that sort of movement and it reproduces pain in the inguinal region, we're starting to think this athlete may have inguinal-related pain.
Okay. So what are the differential diagnoses for groin hernias? Okay, so you just look at the list there. It's quite a lot. So malignancies, primary testicular tumors, and with the complications associated with them, especially testicular torsion, no, which can happen in a patient, which we might confuse with an acute first onset incarcerated, possibly strangulated hernias. They all present with a mass in the scrotum, which is tender, might be associated with fever, and of course, all the other complications that can happen. So another very important differential, of course, is the presence of epididymoorchitis. No? A patient with a history, very important, is a history of unprotected, unsafe sex, which can result in swelling and inflammation, infection of the epididymis in the testicle. They all present with a bulge in the groin extending into the scrotum, which is tender, warm to touch, no? Very similar to a strangulated hernia. Now, of course, very, very important is to be able to differentiate one from the other because one is managed medically while the other is managed surgically. So you have to make sure that your diagnosis is correct. Otherwise, you might do a surgical procedure on a medical case. And it can be the end of your very short surgical career. Okay? So again, as I said earlier, if the diagnosis is ambiguous and you need some additional studies, then imaging studies become part of the equation. So the least invasive, of course, is the ultrasound because there's no radiation exposure, and unless the herniating organ is already ischemic and gangrenous, you will see movement of the herniating organs, no? So intestines moving within the bulge on ultrasound, okay? Now, once in a while, you might have false positive and false negative results, but you just have to be aware of this. So very important is to correlate what you see on imaging study with your PE and of course your history. So management, I'll give you an overview of the approaches for inguinal hernia treatment. So for those patients who are asymptomatic, except for, of course, the bulge, then we can just reassure the patient, and watchful waiting can be the primary mode of management. Now, just advise the patient of the possible complications that can happen, incarceration, strangulation, but very rarely do these complications occur in the absence of symptoms. So if the patient is just complaining of a reducible bulge without any other symptom, then watchful waiting can be resorted to. Okay. Otherwise, if it is symptomatic and if it's bothering the patient, and if the risk, according to your evaluation and assessment, is high for it to develop complications, then we offer the patient surgical management. And of course, there are several options. One is open repair, which is the traditional approach, and it has been proven to be very successful. No? At present, the most common, which we most of the time do, is with the use of a mesh. No? We employ the Liechtenstein tension-free hernioplasty, no? With the mesh. And the use of the mesh can be either through the anterior approach, open repair, or through the minimally invasive approach, no? Through the lap repair, which can either be using the TAP, which is transabdominal, and or the TEP, which is totally extraperitoneal without entering the intraabdominal area. Both of which have advantages and disadvantages, which we will touch on later on. And of course, for those centers with available instrumentation, then robotic surgery can also be performed. When we do robotic surgery, it is also a minimally invasive approach a laparoscopic approach, but of course, with the aid of a robot. But it significantly increases the cost of such a procedure. So treatment options, surgical repair is the definitive treatment. Resorting to the use of trusses or supporters would not definitely take care of the hernia problem. It might offer slight relief to the patient because it can sometimes help the patient maintain the hernia in a reduced state, but it will not solve the defect. Okay? So again, you advise the patient to undergo surgery using either the open or the minimally invasive approach. And most of the time, patient would want to undergo surgery because of the pain. This is the most common reason for elective repair. But when we talk of complications such as incarceration and strangulation, then it will not be an elective procedure anymore. It is an indication for urgent repair. Now, elective repair is only advised for symptomatic patients without complications when they see you. And again, just to stress the point that for asymptomatic hernias, you can advise the patient to just watch the symptoms and just observe the lesion, okay? Because the risk of incarceration or strangulation is low in such asymptomatic patients. So treatment options, now just to point out that asymptomatic patients usually develop 72% symptoms in 7 to 8 years. Strangulation is about 2.8% within 3 months and 4.5% within 2 years. But it is more common in femoral hernias. In femoral hernias, 3-month incidence of strangulation is 22% versus 2.8% among inguinal hernias. Remember, when you talk of direct and indirect inguinal hernias, they occur or they are seen above the inguinal ligament, whereas your femoral hernias occur or you can feel it below the inguinal ligament. So that's one of the easier way of differentiating one from the other because one has a higher incidence of strangulation and incarceration compared to the other. Now, of course, when we see the patient with a symptomatic hernia, we advise surgery as soon as they are optimally prepared and the patient is also ready because an emergency surgery is associated with a 7% or a 7-fold increase in all-cause mortality over elective surgery. When you say 7-fold, that's 700%, okay, 7 times. Then, of course, for femoral hernias and symptomatic inguinal hernias, we advise elective repair whenever possible to decrease the overall morbidity and mortality of such emergency procedures. Now, incarceration is when there is a failure to reduce the hernia, okay? Patients will come to you, see you, and say that they have a bulge which would be precipitated by exertion, but would spontaneously or can be manually reduced when they lie down. No? So this is just incarceration with the ability to reduce it. No? Now, sometimes, depending on the organ system that passes through the defect, no, they can be chronically incarcerated. No? And we're talking here, the most common is the incarceration of the omentum. So when the omentum passes through the defect, sometimes if they are not reduced, they tend to form adhesions with the peritoneal lining or what we call the hernial sac, and they remain incarcerated. No? But a mental incarceration sometimes can last for years with the non-operative treatment without going into strangulation. So if the patient presents with incarceration and the likelihood that it is omentum is very high and there is minimum or minimal symptoms, then it can be treated non-operatively. But we still advise the patient that it's best to have it removed or repaired. Okay. So we call it taxis, no? The attempt to reduce hernia without sequelae of strangulation, which means that if a patient arrives in the emergency room with an incarcerated hernia and upon evaluation, the risk that it is strangulated is low, no? Which means there's no tachycardia, there's no fever, there's no erythema of the overlying skin over the bulge, there's no tenderness, then most likely it's just incarceration without strangulation. Okay, so you can attempt to do taxis and reduce the hernia and convert it into an elective procedure rather than an emergency procedure. Okay, but take note, very important is to not reduce or not to do taxis in an incarcerated hernia with the possibility that that herniating organ is already strangulated. No? Because what happens when you reduce and become successful a strangulated hernia? No? So the ischemic strangulated intestine goes back into the abdominal cavity. So now you have a problem. If you repair the hernia without seeing the condition of the strangulated, the possibly strangulated, incarcerated organ, then you don't know whether it is still viable or not. No? So if you just repair the hernia without knowing the status of the reduced, possibly strangulated intestine, then that patient can develop peritonitis. No? So inoperar mo na, you repaired it, binalik sa ward, and then the next day, lo and behold, the patient is having tachycardia, possibly septic, because the reduced hernia, which was strangulated, is still within the patient. So, very important. You have to make sure when a patient comes in with an incarcerated hernia, indirect incarcerated hernia, that there is no possibility that it is strangulated. Because if it has a possibility, then don't even attempt to reduce it. Okay? In fact, when we bring these patients to the operating room, we make sure that upon induction of anesthesia, wherein the abdominal muscles would relax and enlarge the internal opening, then there is a chance that that incarcerated, possibly strangulated abdominal contents can go back into the abdominal cavity. So what we do is we ask our junior residents to hold on to that incarcerated bulge to make sure that it does not reduce spontaneously when we induct anesthesia prior to surgery. So we will see the viability when we open the sac. Okay? Because if we see that it is non-viable, then we can resect the intestine that is non-viable within the operating field. Okay? Pag pumasok yan sa loob, hindi na natin makikita yon. No? So, sometimes we end up opening using a different incision just to take a look at that bowel to make sure that it is still viable. No? But some surgeons would resort to observing such lesions. Just go ahead with the repair and observe the patient. But you have to inform the patient that, you have not seen the status of the abdominal contents which reduce spontaneously. So there's a possibility that it can be ischemic and can possibly necrose. No? So there's a risk that you will do a second surgery. Either that or you resort to laparoscopic surgery. Upon induction, if it resolved If it reduced spontaneously and there's a risk that it is strangulated, then instead of doing an open repair, you can resort to laparoscopic repair if you are prepared and instrumentation is available, no? Because by doing a minimal invasive repair in that instance, then you will have the chance to see the intra-abdominal contents through your scope, okay? Which you do not have when you do an anterior open repair, okay? I hope that the point is very clear, okay? So of course, when you attempt taxis, you have to give your patient analgesics. You have to sedate the patient to make the muscles relax, and of course, put the patient in a Trendelenburg position. So an indication for emergent inguinal repair is an impending compromise of intestinal contents. Now, again, just to reiterate, clinical signs of strangulation includes tenderness, fever, leukocytosis, a patient who has hemodynamic instability because of impending sepsis, then most likely this is already strangulated. Of course, once your patient presents with frank signs of peritonitis, then there's no question. It is already strangulated, so be prepared to resect bowel. The more challenging point is in a patient with an incarcerated hernia beginning strangulation, but with still a viable intestine, which might not need resection. So it is in that instance that it is very important to act, ano nga yung word nila sa Supreme Court, yung you have to do it immediately, forthwith, right? You have to decide right there then to open up the patient, hoping that the beginning strangulation will not proceed to frank strangulation and cannot be reversed, no? Because we know that once tissue is dead, a tissue is dead, isang tao lang ang makakabuhay ng patay. Okay? And that is Jesus Christ. Okay? So, a hernia bulge is usually warm, tender, and the overlying skin is erythematous or discolored. Okay. Presence of signs of intestinal obstruction. Of course, if you have incarceration and strangulation of a segment of intestine, then the patient will develop intestinal obstruction. Lalaking tiyan, and then of course tenderness. So if you are suspecting strangulation, then do not do taxis or even attempt to do taxis. Okay, we use prophylactic antibiotics. Of course, if it is complicated, then we do definitive antibiotic treatment. But in elective surgery, we just give one dose prophylactic antibiotics, and it is routine for inguinal hernia repair. And for the open or lap procedures, we do mesh repair, which is the most common. And then, of course, we still have to learn how to do tissue repair because sometimes in overtly infected instances, like for example, when you open up a strangulated hernia, there's frank necrosis and you have to resect and there is spillage, then we don't use a foreign body. No, we don't use a mesh because it will increase the incidence of post-operative infection. So we resort to tissue repair. That's why we still teach our residents tissue repair, even if we don't perform it most of the time. Because there might be instances when one needs to perform a tissue repair. And in the presence of an infected field, then this is one indication to elect to do tissue repair. So open approach, this is the traditional technique, okay? So you can see there in the illustration, an incision, a transverse incision in the right inguinal area. And this can be performed under local or spinal anesthesia. Most commonly, we use a mesh. It is cost-effective and reliable. And of course, currently, it is associated with the least recurrence, which is it is the basis for choosing a technique for hernia repair. One that is associated with least recurrence. Okay? Tissue repair is performed if prosthetic material is not available or is or the surgeon is not confident that it can be safely performed, especially in dirty, contaminated hernia repairs. No? So this is, of course, happening when there is fecal contamination from a perforation or when the viability of the hernial contents is under question. So we talk about open repair. So tissue repair, there are several options. No? One is your Bassini, which is basically, can you see my pointer?
Yes po, Doc.
Okay, so for Bassini, no, we suture this area, no, which is some would label it as the conjoined tendon, but that is only seen in a very few patients. Most of the time, we use the two layers here in the upper border, which is the transversus abdominis aponeurosis and the transversalis fascia, and we suture it to the Puppert's ligament here. No? So suturing we call it the TAATF, or in some instances, the conjoined tendon to the inguinal or the Pupper's ligament here is what we call the Bassini repair. Okay? So you can see it there. Of course, Schuldeis repair, more or less the same, except that it is performed in several layers. No? And of course, when you do several layer repair, then it becomes stronger and the recurrence rate is much lower compared to the Bassini repair. Of course, when you talk of femoral hernia, then you have to also close the foramina where your femoral hernia occurs, no? And you cannot do that with a Bassini repair. So you have to open up this area here to expose the Cooper's ligament, and medially we suture the TAATF to the Cooper's ligament, okay? And then laterally we proceed with the TAATF to the Cooper's ligament. So para naging Bassini siya going lateral. But medially, instead of the Poupart's, we use the Cooper's ligament to the TAATF. No? Yun lang naman yung difference between a McVeigh's repair and the Bassini repair. Okay? Just to give you an idea how it is done, but of course, this is more of a higher level learning. And of course, in the late 20th century, Disarda introduced this kind of repair. No? It is a multi-layered repair also, and it is also a tissue repair. The main difference with Bassini and McVeigh is that here you try to make a relaxing incision here, and it decreases the tension on the repair. Because as you see, one of the common or the most common cause of failure of repair is the presence of tension in the repair. That's why the use of a mesh became very popular because it's tension-free. No? The Liechtenstein repair is also called a tension-free hernioplasty. So there's no tension because you don't pull one part and attach it to another part, which is of some distance from each other. No? When you attach this part to this part, then there's tension there. But when you just lay a mesh here without pulling one tissue into the other, then there's no tension. No? So it's tension-free, and it is associated with lesser recurrence. The same holds true for the Disarda repair, no? Because there is what we call a relaxing incision here. Okay? This is just nice to know. So, of course, the most popular and associated with the least recurrence is your prosthetic repair. And, of course, the very popular procedure now is the Liechtenstein tension-free hernioplasty. No? and it involves laying down the mesh on the defect, no? And after ensuring that there is no tension in the cord structures, you put a keyhole, and of course, you suture you anchor your mesh into the same area where you're supposed to suture when you do your Bassini or your McVeigh repair, no? Which is into the inguinal ligament and into the TAATF. Okay? So the purpose of the suture is just to keep the mesh in place and not to migrate, rather than to make it parang matigas siya and tight, no? We don't make it tight. Just we use the sutures just to hold it in place and prevent migration. In fact, initially before, they don't use sutures pa, no? But we have observed that through time, the mesh would shrink, no? Pero in patients when we had to do a redo operation several years after, we cannot even differentiate the mesh from the normal tissue kasi fibrosis would grow into the mesh, no? Kaya may butas-butas yan eh. Pumapasok dyan yung normal tissue ng tao. So it becomes one solid, firm tissue. So there are several options with the use of a mesh. One is plug and patch, no? So this is a two-type. It involves two procedures. One is use of a plug. So we insert the plug into the internal ring, I mean. Okay, and then once it's anchored, we put the mesh, just like what we do with the Liechtenstein hernioplasty, no? So dalawang mesh siya. Naka-plug sa butas, and of course, yung mesh na ino-overlay dito. Okay? So prosthetic repairs involves placing a synthetic or biological mesh. It is tension-free, and it is now considered the gold standard, no? Including for incisional hernias. And this can be performed using the different surgical approaches, either anteriorly open approach or minimally invasive laparoscopic approach. So when you opt to do your laparoscopic approach, you can either use your top repair, wherein we enter the abdominal cavity. It's a transabdominal preperitoneal repair. You enter the cavity and then you incise through the peritoneum and insert the mesh between the peritoneum and the transversus abdominis aponeurosis and the transversalis fascia. Now, in contrast to your TEP, which is totally extraperitoneal, you don't penetrate the intra-abdominal area. No, you totally perform it extraperitoneally. So it's totally extraperitoneal. Okay, and of course the IPOM technique, no, which is an onlay mesh repair. No? So when you do laparoscopic procedures, we can only do this under general anesthesia. So in patients who are at high risk for general anesthesia, then we don't offer minimally invasive surgery for them. No? We just advise them to undergo open anterior approach. Okay. Now, of course, when you have a patient who presents with bilateral hernias, then the laparoscopic approach is the better option. Why? Because you only have to perform one additional port, no? Unlike if you do the anterior approach, then you have to make two separate incisions. One on the right and one on the left. Dito, pag laparoscopic, isa lang. And you can perform repair of both the right and the left using that single approach, except that you only add one additional port when you work on the other side. Okay? So it is the superior approach for recurrent or bilateral hernias. Why for recurrent? Because for us surgeons and for the patient, it is best to perform surgery on a virgin area. No? Pag anterior approach and it is a recurrent hernia, then you will be encountering a lot of adhesions and the area is already very, very difficult to dissect. And you expose the patient, there's a higher risk of damaging the ilioinguinal and the iliohypogastric nerves. Okay. Whereas if you approach this intra-abdominally or using the TEP, for example, then you don't pass through the previous scarred area. So you approach it through a virgin area, which make dissection a lot easier and a much safer for the patient from complications that can happen. Okay? So whenever we see a patient with an inguinal hernia, we also make sure that we inform the patient, especially if we do the lap technique, that there's a chance that we can see another hernia in the other area, no? Because it's the same patient, it's the same risk factor. Okay? So may chance talaga na meron siyang hernia din sa kabila, no? And the patient should be aware that there's a possibility that instead of one, of course, you will be performing two sides. So just to show you the final resting place of your prosthetic mesh in a top repair, okay, and its relationship to the anatomic structures. And of course, when the TEP, with the TEP repair here, you insert an instrument with a dilator to create a space anteriorly but without entering the abdominal cavity, no? So this is extraperitoneal. This is the preperitoneal space. This is what you dilate, make a space so you can perform it safely. And then, of course, the technique is the same as your top repair, except that you do this without entering the abdominal cavity. Sa top kasi, papasok ka dito sa loob and then you incise the visceral peritoneum here to gain access to this area. Sa TEP naman, you don't have to incise na here kasi you're in the extraperitoneal space to start with, no? So yun lang naman ang difference ng top sa TEP, no? Okay? Sa TEP medyo more challenging kasi magda-dissect ka pa na magki-create ka pa ng space. Sa top, once you enter here, you just open the visceral peritoneum here and then ito lang yung i-dissect. Okay? Again, nice to know. Okay, sa IPOM naman, you access the preperitoneal space without intraperitoneal penetration and same advantage, no? It minimizes injury to intra-abdominal organs. It can be used for bilateral hernias. And again, this is the better option, no? Top TEP IPOM for recurrent hernias who underwent anterior approach previously. So it involves the application of that mesh, no? So just to show you the positions of the mesh in relation to the anterior abdominal wall structures. So whether it's sublay, onlay, inlay, okay, underlay, and intraperitoneal. Okay, pag intraperitoneal IPOM, this is again a different type of mesh, no? The regular mesh that we use for the Liechtenstein repair or for the top or the TEP, ano siya, it's made of polypropylene. And it cannot come in contact with intra-abdominal organs because it can cause adhesions and perforation, no? That's why if this is your peritoneal cavity, no, we incise this and we insert the mesh between the peritoneum and the abdominal wall, no? So that when it is already placed, we close the peritoneum. So the peritoneal cavity, the intra-abdominal cavity, I mean, is not in contact with the mesh. Pero pag IPOM, we place it intraperitoneally, and we use this technique during repair of huge umbilical hernias, for example. No? So, umbilical hernia, nandito yung butas, we place the mesh below the peritoneum, intraperitoneally. Now, this is a different kind of mesh. Because the area that is in contact with the abdominal cavity is coated with substance that is safe to come in contact with the intra-abdominal contents. No? So, mas mahal siya because of that coating. Okay? I think 70,000 yung ginagamit namin or 100,000 for the mesh only. No? When we use that for huge the umbilical hernias. Okay? So of course, robot assisted, you only use the robot to hold on to the instruments, unlike, of course, when we just do the classic laparoscopic repair, we hold on to the instruments. Pag robot, yung robot ang humahawak ng instruments, and then you do surgery from a console. No? He's the surgeon, sa console siya, lahat ng movement niya, nire-reproduce ng robot. Okay? And then you just view what's happening in the monitor. No? But of course, this is only available in some select centers, and it is very expensive. Now, initially, a few years ago, to perform a robotic surgery would cost a patient more than 1,000,000 pesos. But now, there are a lot of, kasi ng original yan, Da Vinci, no? Da Vinci robot. Medyo mahal yun eh. I think 60, 70 million yung machine, no? But now, China and of course, the other nations are making cheaper robots. The procedure now is significantly lower, still more expensive than a traditional lap approach, but more and more people can afford it. No? I heard from the grapevine that aside from the flood control projects, no, acquisition of these cheaper robots is now one also of the source of corruption in the DOH. No? May nagsabi lang sa akin. No? So how do they do that? No? Like for example, a 20 million robot ends up costing 60 million. No? So you know where the 40 million goes to, right? Anyway, that's what it is. So prosthetic considerations. When you choose a mesh, an ideal mesh should be easy to handle, flexible, immunologically inert, okay? Hopefully contraction resistant and infection resistant and cheap. Most of the time, it's made of polypropylene or sometimes polyester, no? But mostly we use polypropylene, but there are also other meshes that incorporates absorbable materials rather than purely non-absorbable, because polypropylene is non-absorbable. And it, of course, makes it a little more flexible. Okay. More of the considerations, of course, it should hopefully, if you don't use a pure polypropylene mesh, there's some parts of the mesh that can be absorbed, no? And the thickness, the weight, all of these things are important considerations when you choose a mesh, no? Now, in some countries where they need to use a mesh, but it's not available, like for example, in India, historically, they used mosquito nets, no? from polyethylene materials, and when they evaluated the patients post-op, their results were quite considerably comparable to the use of your polypropylene mesh, no? So, pwede rin. Okay? Same principle, except that you use a different material. So, of course, treatment options, incarceration, when you're not able to reduce it, non-operative for minimally symptomatic. Okay, I think we talked about this kanina. And of course, aside from the acute complications post-op, no, which would include all of these things, you have also chronic complications, which can result from compression of the nerve, or hopefully not, transection of the nerve, mesh fibrosis, which sometimes may involve the nerve, which can cause chronic pain. And of course, worse is testicular atrophy kasi na-compromise yung vascular supply ng testicles. Lap-specific, vascular, nerve injury, visceral injury, all of this can happen when you do lap hernia repair. And of course, the basis for choosing the better option is recurrence, which can either be a technical error or a mesh failure. Okay, some of the risks for recurrence, of course, diabetes, anti-inflammatory use because it hinders repair of tissues, your steroids, and technical issues. Maliit masyado yung mesh na ginamit, no? There's tissue ischemia, infarction, or presence of infection. There's tension in the repair, which is, of course, as I said, very unlikely when you use a mesh, unless, of course, you're not very proficient in what you're doing. So sometimes we use imaging studies when the physical finding is ambiguous and we cannot rule out or rule in one from the other when we're trying to do our evaluation of the patient. Okay? We can resort to the use of the ultrasound, CT, or sometimes MRI, but very unlikely. And all of these complications, again, are minimized with the utilization of a virgin plane when we do redo surgery. Okay? So more of the complications, okay? So treatment can be with NSAIDs, and of course you just have to reassure the patient that this is just a temporary thing, hopefully, and will resolve with time. Now, mind you, chronic post-op pain, it can be as high as 63%. That's why it is very important when you do your surgery, whether anterior or lap approach, to take note that you don't injure nerves when you do this surgery, no? Because they can result in chronic pain post-op, and this can be debilitating to the patient. It can be as high as 63%. No? So we call it inguinodynia, okay, or pain in the inguinal area. So it's very debilitating, and treatment can involve, lysis of the adhesions if it is just adhesions, or if there is a neuroma or myxoma, then you have to take care of that. No? Some would even result in performance of a triple neurectomy, okay, with the removal of the mesh. Okay, so you have to, of course, prevention is key to avoiding these complications. Okay, so it can be neuropathic, again, visceral, or, as I said, 63% chronic post-op pain. Teka, bumalik ata tayo. Now, okay. So treatment can be with rest, NSAIDs, physical therapy, and of course, pain medication for neuropathic type of pain, which can be example of which is your gabapentin. Okay. Now another complication is when your suture would injure the pubic symphysis, no? And it will cause inflammation of the pubic bone, no? So we call that osteitis pubis. So patients will present with medial groin or symphysial pain, and this can be reproduced by abduction of the thigh, no? So one is you want to make sure that this is not a recurrent hernia in the medial aspect of your repair. So imaging studies might be indicated, no? And then you can use also request for a bone scan because the bone scan will show you osteitis pubis, no? There will be inflammatory and sometimes lytic changes in the pubic bone. Okay, so it can be managed essentially conservatively, but if it is persistent and refractory to medical management or conservative management, then bone resection can, with cochlear rods, can be performed. Okay. Now, of course, during the repair, you can devascularize your testicles or your cord, okay, and you can injure them. So ischemic orchitis or testicular atrophy with slow but chronic ischemia can result. Okay. It can manifest within 1 week of surgery, and it presents with an enlarged, indurated, painful testis, which is self-limited. So imaging studies is very important, and we utilize this. Very popular is the use of the ultrasound, because it can help us differentiate just pure ischemia or simple ischemia from frank necrosis. Now, when you injure the testicular artery, you can it can result in testicular atrophy. Okay, but remember that testicles is not just supplied by the testicular artery. No, it has supply coming from the vessels from the scrotum and of course within the spermatic cord. So for ischemic orchitis, which is not frank gangrene, you can reassure the patient, use NSAIDs, and comfort measures can be employed. Okay. So intraoperatively, when we do surgery, we make sure that we ligate the hernial sac proximally. There are only two basic principles when you do elective hernia repair, no? Or even emergency hernia repair. And one is high ligation of the sac, and two, strengthening of the floor. Remember that. Two basic components of hernia repair. One, high ligation of the sac, and two, strengthening of the floor. When we say strengthening of the floor, either tissue repair, Bassini, McVeigh, Disarda, or the use of a mesh. That would strengthen the floor. But everything else would involve also ligation of the sac. And we do that at the level of the internal oblique muscle, no? Before it becomes the cremaster muscle. Okay? And proximal ligation of the hernial sac avoids cord manipulation that can result in injury to the spermatic cord structures. Okay? So, more of the complications, no? So, very important to minimize perioperative fluid administration. Dahan-dahan lang, no? You just remind your anesthesiologist, o wala kaming bleeding dito na in-expect. So, dahan-dahan lang yung fluid administration. We don't want the patient to go into urinary retention, especially with patients who underwent hernia repair using spinal anesthesia, for example. Okay? So, complications of lap hernia repair, ileus, bowel obstruction because we approach it intra-abdominally for the top. And then sometimes it may require decompression of the patient just maintain the patient on NPO, no? So just to make sure sometimes that this is not just ileus but obstruction, then we might result in the use of imaging studies. Because when a patient develops true obstruction post-op from a hernia repair, then it might, need reoperation. No, of course, there's room for observation initially because if ever this is from post-op adhesions, then it is early post-op adhesions. It's just soft, no? Soft adhesions. It might improve with time, no? But if it is acute onset na sobrang mabilis yung progression, then maybe something happened inside and it might warrant an emergency surgery, no? For laparoscopic surgery, for example, sometimes we do not see. That's why we make sure that when we do cautery, we see the tip, no? Minsan, pag hindi nakita, nagko-cautery, baka or may defect doon sa electrocautery unit, no? Mayroon palang nawala na insulating agent proximally, hindi mo alam. That's why we inspect it before we perform the procedure. Kasi pag may butas yung insulation ng cautery intra-abdominally, pwedeng may nakadikit na bituka doon, susunugin niya. And since the camera is not directed to that area, pwede mong hindi mapansin, no? And when patients develop abdominal signs or peritonitis post-op from a lap repair, then you should entertain ischemia. Okay? So, all of these things are avoidable. Okay? Bladder injury is one of the complications, no? So sometimes patients develop abdominal distension, and when you need to do repeated catheterization to just relieve the bladder distension, then you might need to insert an indwelling catheter, no? Especially if your initial drain is more than 600 or sometimes 1 liter of urine, then you need to rest that overstretched bladder, no? So 1 to 2 weeks of indwelling catheter, you send the patient home with a catheter, and hopefully in 1 or 2 weeks that bladder is rested and can resume its decompression abilities or compression abilities, no? Some would even resort to a cystogram prior to catheter removal. Of course, the most severe complication which can be catastrophic is vascular injury, no? And this can happen when you do the anterior approach, open approach, or laparoscopically, from a misplaced suture or with the use of your tackers if you misplaced placing the tackers when you do your lap repair, no? Or sometimes during your dissection, no? And depending on the caliber of the vascular structure that you injure, then it can result in strangulation of your patient, and it can be swift, no? And it can flood the area, and it can cause so much stress and panic, and hopefully not death in your patient. Things that we don't want to see when we do surgery, no? That's why very important is to take note of all of these landmarks, no? Triangle of doom, triangle of pain, when you do your minimally invasive procedures, no? You can just look it up in your textbook. Okay? Sometimes bleeding do not occur until such time that you terminate your procedure or decompress the abdomen. Kasi mataas yung pressure in the abdomen when we do laparoscopic repair, because of the infused carbon dioxide in the abdominal cavity. So kung hindi naman ganun kalaki, sometimes walang bleeding, pero pag nag-decompress na, doon magsa-start pag-bleed, no? Especially if it is just a venous injury kasi mas mababa yung pressure involved with your venous supply, no? Okay? So hematomas, seromas can both occur in your lap or traditional anterior approach. Seromas can happen 1 week after surgery. You just reassure the patient, and you don't aspirate seromas unless they cause a lot of symptoms on the patient. No? Outcome, of course, recurrence is one of the parameters that we utilize to assess the type of technique that we need to perform on the patient. And as I said, and I want to reiterate that as of today, the least recurrence, which is the basis for choosing a technique over the others, is your Liechtenstein tension-free repair using mesh. No? For, of course, for use of native tissue or tissue repair, Scholdeis repair. No? So very important after a repair is maintain heavy weight, a healthy weight, adopt proper lifting technique, hopefully quit smoking, okay, use breathe easy, stay active, and of course control constipation, COPD, and LUTS. No? If you have an enlarged prostate, then maybe a medication or surgery can take care of the problem. Okay, if you have COPD, then adequate medications, constipation, adequate medications. No, we want to avoid straining, no, which can compromise repair. That's why it is very important prior to repair to make sure that you have an optimally prepared patient. No? So doon sa review of systems, you have to review history of chronic cough, constipation, or LUTS. If your patient is suffering from one of them, make sure that it is optimally maximized ang control ng exertion prior to surgery. Otherwise, it will compromise surgery. No? Can you imagine, nag-repair ka ng hernia and then in the recovery room, your patient started coughing and coughing and coughing. Huh? It can put so much strain on the repair, especially if you did a tissue repair which has some sort of tension in the first place. Okay? So, optimized patient prior to repair. Okay? So, any questions before we proceed to the other minor topics? No? In the exam, most of my questions will be centered on the inguinal hernias. No? So, any questions so far? Walang question? Matulog na lahat? Okay, so 1 minute break. Okay, 1 minute break before we talk with the rest of the topic for this morning. Okay, so let's continue with the rest of the morning. We talk about the other conditions associated with the abdominal wall, the omentum, the mesentery, and of course the retroperitoneum. So just recap. This is your abdominal wall with the different layers, okay, from external, most superficial, up to the internal or the peritoneum, okay? And the different surgical incisions that we utilize from of course, the midline incision, midline longitudinal, paramedian, okay, the chevron, subcostal, transverse incisions, McBurney's incision, Fanning steel. Of course, basically, transverse incisions are associated with lower incisional hernias, no? But they have a higher rate of infection, okay? And of course, very important is the exposure that they provide, okay? You want to make sure that the incision that you choose will provide you with the best exposure for the procedure that you are contemplating to perform. That's why when we use the term explore lap, no? Which means we have to explore and have access to the whole of the abdominal cavity. The preferred incision is your midline vertical incision. Okay? So the most common is your midline incision. Paramedian, just lateral to the midline, is through the rectus sheath or in the pararectal location. No? It restricts access to the contralateral abdomen. But in instances where you're sure that the pathology is on the preferred site, especially for example, if you're talking of possible ruptured appendicitis, then if you elect to do a midline vertical incision, a right paramedian incision can be your choice. Okay. And then, of course, the transverse or your horizontal incisions. There are several defects associated with the abdominal wall, no? Your omphalocele and your gastroschisis, no? The main differentiating factor here is the presence of your peritoneal membrane covering what is herniating, no? With omphalocele, merong peritoneum lining, but with gastroschisis, wala. Okay? So, with gastroschisis,
Recording stopped.
with gastroschisis, there is true disruption of your abdominal wall, no? Either from a genetic defect or a vascular compromise. No? Oh, the recording stopped, huh? So if you want to record, you just have to re-record again. Okay. Okay. Well, you have vitelline duct abnormalities, your omphalomesentéric fistula. Okay. All of this, you have to read on this. And of course, your urachus, which can be either a cyst or a fistula. Acquired abnormalities, we will dwell on this a bit, no? These are your abdominal wall hernias, okay? And just like your inguinal hernias, there is a resultant protrusion or bulge in the of the abdominal contents through the abdominal wall. Huh? So it can either be asymptomatic or it can cause significant discomfort on the patient. And just like your inguinal hernias, they can also incarcerate and result in strangulation. So the same principle applies, no? When you are entertaining possible strangulation, then there are signs of obstruction, there are systemic signs like fever, and sometimes even leukocytosis, no? So, of course, when you talk of strangulation, it will ultimately lead to perforation. So you have to address it ASAP. Okay? Now, umbilical hernias, it can be congenital or acquired. If it is congenital, then initially, if the risk of strangulation or incarceration is very low, you can advise the patient or the relative or the mother, father that this can close spontaneously. So you can observe it. Some would say 2 years, but we can observe it until 5 years. No? Now, of course, if there is a chance that, or if it is incarcerated or symptomatic or failure to close in 5 years, then you advise repair. For adults, it is usually because of increase in intra-abdominal pressure. So you have to identify the causative factor and address it if it is controllable. Like for example, nabuntis yung patient, nagkaroon siya ng hernia, then you can observe the lesion post-partum and see if it is progressive or it will cause a lot of symptoms on the patient. Otherwise, you can just observe it. So this is more common among females. Now, if there is increase in size or there is a chance that this is incarcerating or strangulating, then you advise surgery or do immediate surgery if it is possibly strangulated. Of course, if the defect is more than 2 or 3 centimeters, use a mesh, okay? Because if you approximate the defect using sutures, then in the presence of a large defect, it can cause tension. And as I said earlier on, tension is one of the more common causes of failure of repair. So use a mesh to bridge the gap. Okay. Some would use onlay mesh, which means that they suture and then after approximation, they put an onlay mesh. Some would use a bridging mesh, which means you don't suture, you maintain the defect, but you put a bridge to approximate both defects. There is no tension, but there is a bridging mesh in between the defect. Okay. Spigelial hernias. Okay, just read on this. Now, of course, incisional hernias happen when post-op your patient develops a hernia. For example, you did an appendectomy or you did a cholecystectomy. Then after a year or two, your patient went back to see you with a bulge in the area. Okay, so that's labeled as an incisional hernia because it happened where you place your incision. So there are several factors that can result in an incisional hernia, and the very common is a technical factor. You place your sutures very near the edge. Okay.
Recording in progress.
You have a patient who has systemic diseases, a diabetic patient, okay, patient with consistently increased intra-abdominal pressure, like a patient with COPD, uncontrolled coughing, okay, or a patient with worsening LUTS, malaki yung prostate, tumatanda ang patient, ire ng ire every time he urinates, or chronically constipated patient, he has to strain so much to move the bowels. All of this can result in an incisional hernia. Okay? So very, very important. When you do surgery for these patients and you have recognized all of these risk factors, you have to advise your patient of the possibility of this from happening. Okay? There is no other way to prevent future litigation.
Recording stopped.
There is no better way than a patient who has been made aware of the possible things that can happen in the future. Okay? So it can happen in 20% of midline incisions. As I said earlier on, upper abdominal incisions at higher risk than lower abdominal incisions. And vertical incisions have a higher risk compared to transverse or oblique incisions from developing hernias. Yung ano naman, kabaliktaran naman dyan, of course, is higher ang incidence ng infection. Okay? With transverse incisions.
Recording in progress.
So risk factors, okay, all of these things. Very important is your local operative factors. No? So you have to make sure when you do the surgery, you have to be meticulous with your technique. Huh? Dr. Martinez, one of my senior consultants, would always tell us before when we were training to be kind to the tissues, and the tissues will be kind to you. Okay? So very meticulous technique. Okay? So make sure you don't develop infection. Kasi infection, yan ang very common cause ng disruption ng repair. And in the operating room, pag nagkaroon ng infection, in a class 2 or a class 1 wound, most likely ang source ng infection is the clinical clerk. Kasi nag-scrub sila, nagkaroon ng breaking technique, pero natakot siya dahil baka makita ng consultant, itinuloy niya na lang yung pag-scrub kahit na hindi dapat mag-rescrub siya. No? So, joke lang yan. That's our common OR joke. No? Pag nagkaroon ng infection, we always blame the lowest in the hierarchy, and it's the clinical clerk. No? But there are a lot of factors, you know that, right? So, we make sure that all of these things are corrected. No? So, kayo, in the next few months, you'll be clerks. Make sure that when you scrub and join the operating team, you make sure that you are aseptic. Your technique is perfect. Okay? So you don't introduce a possible source of infection. Okay? And of course, incisional hernias can develop even up to 10 years after surgery. Small defects poses a higher risk of incarceration, use of primary tissue or mesh, no? And have different incidences of incisional hernias. Simple suture repair is associated with 54% recurrence rate. Again, because of the tension. That's why you have to be very selective and very careful when you do your closure of the abdominal incision. Mesh repair, lowest recurrence. But of course, because you use the mesh, that's a foreign body can result in a higher risk of infection. That's why when there is a chance that you are dealing with an infected or dirty surgical field, as much as possible, we don't use a foreign body. We only use the patient's native tissue. But otherwise, in the absence of potentially contaminated or an actually contaminated or dirty wound, we use a mesh. Okay? And for incisional hernias, the sublate technique is recommended. Okay? Now, rectus abdominis diastasis, no, can just be temporary. So you just have to evaluate the patient carefully. And if you think that this is just temporary, you just advise your patient weight loss and exercise. No? So the rectus abdominis muscles will become developed, and hopefully the diastasis will decrease in size and ultimately will result in an asymptomatic patient. Hematomas in the rectus sheath, okay, can result when there is a disruption of the branches of the inferior epigastric artery. So some other causes can be from trocar placement, sometimes even with just vigorous muscle contraction from sneezing or coughing can result in a hematoma. So they can present with pain with an abdominal mass which is aggravated by contraction of the muscles. And usually confirmed by ultrasound or CT scan, and you can just observe this, no? But if it is progressively enlarging, then several options are available, including angiographic embolization or sometimes just doing surgery and identifying the actual source of the bleeding, which sometimes can be also very difficult. No? Minsan, pagbukas mo, kita mo yung hematoma, but after you evacuated it, hindi mo na mahanap yung source. No? So that becomes very challenging. So just make sure that whatever option you elect to do, it will hopefully result in a positive outcome. So you can read on your tumors, your desmoid tumors, okay? But all of these are neoplastic lesions, no? Which has no metastatic potential, and of course, you have to do biopsy on these lesions. No? So if they are asymptomatic, abdominal wall desmoid tumors can just be observed because these are non-life-threatening. If it becomes symptomatic, then you advise surgery. Okay? Because enlarging tumors can invade surrounding structures by external compression. No? So sometimes they can also invade infiltratively, and there's a role for radiation therapy for these instances. No? Okay, now let's go to the omentum. So the omentum is the apron here, whose primary role is to act as the policeman of the abdomen. No? So kung saan may problema, just like the police, they go there. No? If you have an inflamed tissue, then the omentum will go there. Okay? You have inflamed appendix. Pagbukas mo, you will see that appendix, unless of course it's a young child wherein the omentum is not yet fully mobile, or a very elderly individual wherein immune status or the immunity system, the immune system is not so much responsive anymore, then hindi na siya nagpupunta doon. But in the general population, whenever there is an inflammation, your omentum will do its job. It will go there. Pag meron kang ulcer, pupunta yung omentum doon. Meron kang diverticulitis, pupunta omentum doon. Meron kang appendicitis, pupunta omentum doon. Because their function is to limit the spread of the inflammation and the infection if and when there is perforation that can happen. No? So it is the policeman of the abdomen. It forms fibrin and adheres to the area of inflammation. Okay. Now, sometimes it can even close a perforation, like perforated peptic ulcer. No? Minsan, gugulat kami, pagbukas namin, wala na yung butas kasi there's already fibrin and, the omentum performed its function. So, aside from the leakage of gastric juice, which initially happened, wala nang leakage moving forward. No? That's why we use the omentum to repair these kind of perforations if they are not yet taken care of by the omentum. No? And repair of perforated peptic ulcer using an omentum is what we call the Graham patch repair. No? So sometimes they can infarct, no? And it's one of the rarer causes of abdominal pain. Sometimes they can undergo torsion, they can undergo thrombosis. Okay, all of this can result in pain, and if they irritate the visceral peritoneum, then they can produce signs of peritonitis, and sometimes may be the cause of exploring the patient. Okay, so for these acquired disorders, then imaging studies is very important. Huh? Because you don't want to open up a patient unnecessarily. Okay? Although most of the time, we are not able to diagnose it preoperatively. But in the persistence of peritoneal irritation and signs of peritonitis, even if imaging studies do not show anything, then sometimes we are forced or obliged to open up the patient. So that's the truest form of exploratory laparotomy. No, kasi di mo alam kung ano yung makikita mo. Of course, every surgeon would want to have a roadmap. We want to make sure that we have a working impression going in, but in the persistence of signs of peritonitis with systemic signs like fever and leukocytosis, but with an absent definite diagnosis, we still need to open up the patient. No? It's better to open and see nothing than leave the patient and don't open up the patient in a patient with a true surgical abdomen because you're scared to open up the patient na wala ka namang definite diagnosis. Okay? Usually, pag may peritoneal signs and systemic signs of sepsis, then usually you will see something. Okay? So it's better to commit sin of commission rather than a sin of omission in this instance. As long as your patient is aware pre-op. That's why it's very important for us surgeons to obtain what we call an informed consent. Okay? An informed consent, I'm sure you've talked about this in your legal medicine. It is the best way to prevent litigation in the future. And when we say informed consent, it's the surgeon talking to the patient, talking to the relatives of what's happening to the patient, of the possibilities that you can encounter when you open up the patient. Possible intraoperative decisions, possible post-operative complications, even the possibility of death. You should not say that, this is just a walk in the park. Never do that. No? You tell the patient, of course, magtawid ka lang sa Aurora Boulevard, there's a chance na masagasaan ka, mamamatay ka. Right? Ito, operahan ka pa. So there's really a chance na magkaroon ng complication, magkaroon ng death. But, of course, you have to mitigate that statement. No? I cannot say na zero chance of dying from appendectomy. No surgeon in his right mind will say that's the zero chance. No? But you can mitigate that by saying na, of course, the chance is very, very small. Maybe less than 0.01%. No? Very small, but it's not zero. Okay? So there are several diseases that will involve the omentum, like your omental cyst, okay? And it can be pre-malignant, and the preferred treatment is resection. Neoplasms can involve the omentum, and most of the time they are metastatic from the ovaries, from the GIT, okay? Primary tumors is very rare. And when you say primary tumors, most of the time they are benign, lipomas, myxomas. Okay? So most of the time they are metastatic, involved with metastatic disease. So if they are involved with metastatic disease, then you might need to remove it if it will improve the survival of the patient. No? Now, nowadays, even with metastatic or what we call carcinomatosis involving the abdominal wall and the mesentery, there are procedures that are performed to remove everything. No? They remove the visceral peritoneum as much as possible. They remove the whole omentum. Okay? And this is what we call cytoreductive surgery. And after cytoreductive surgery, they infuse chemotherapy into the abdominal wall. They call it IPEC, no? They infuse chemotherapeutic agent into the abdominal wall. And one of the surgeons in UE who performs that is Dr. Cecilio Hipolito, o si Jay, no? He does IPEC. It's a 12 to 14-hour surgery. No? They remove everything. They strip the peritoneal lining of the abdominal wall. No? Visceral peritoneum, tinatanggal lahat yan. Omentum, no? Lahat. And then infuse chemotherapy, no? And the results are promising rather than allowing the patient to have chronically ascites, malignant ascites, no? At least, but of course, it's not curative, but survival is somehow lengthened, and the patient can have an easier remaining days of his or her life. No? So it's more of palliation. And patients are sometimes happier that way. No? They live a little longer, more time with family, and more comfortable. Okay, just read on the mesentery. Mhm. And of course, sometimes mesenteric defects can result also in what we call internal hernias. Okay. If they are extra long or the length is more than what is necessary, then they can also result in volvulus, no? The bowel will turn around its axis because of a long mesentery. It can happen in the sigmoid, okay, which is the most common, sigmoid volvulus, and of course, even the cecum. Huh? The cecum can twist, okay? Some would involve the vasculature of the mesentery, sclerosing mesenteritis. Some would have fibrosis of the mesentery with unknown causes, mind you. Okay, all of this will present with abdominal pain, nausea, vomiting, weight loss, altered bowel habits, etc. Okay. So you can see a fat ring sign, okay? Preserve fat near the mesenteric vessels, and treatment is complex. If you have sclerosing mesenteritis, you can resect the mesentery, but of course, it will also involve resection of the bowel affected by the resection of the mesentery. If it is obstruction, then you can bypass the obstruction as long as you are not leaving ischemic or ischemic bowel inside, no? Because that can cause ongoing and persistent pain. Okay? Mesenteric cyst is one of the benign but rare disorder, but I have seen it. Okay? And it's because of the accumulation of the lymph fluid from disrupted lymphatics in the mesentery. They're mostly unilocular, and they can present with a lot of symptoms, no? Pain, anorexia, distension. Of course, depending on the location, it can cause change in bowel habits with concomitant distension and, of course, bowel obstruction, signs of bowel obstruction. Okay, so they can present with a mass, and they can be seen with imaging studies such as an ultrasound or a CT scan. 3% of which can be malignant. No? That's why sometimes we need to go in and resect it. Okay, treatment is only surgical. Initially, it was just more marsupialized and aspirated, but this is associated with a higher recurrence rate, even if it's benign. Okay, so you have to remove it, enucleate if it's benign. If it's malignant, then of course you have to remove as much tissue to ensure that you have clear margins and the resected bowel do not result in involved bowel that you leave behind. No? So you have to make sure that you have clear margins. Some other tumors also, it would include your desmoid tumors, lipoma, lymphoma, which is the most common. Okay. So you cannot remove everything, no? When you talk of lymphoma. That's why treatment is medical, chemotherapy, no? but you might need to do surgical intervention just to obtain tissue for biopsy. Okay? Of course, you have other kinds of tumors involving the mesentery, like your GIST, carcinoids, etc. And treatment would involve wide resection. But when you talk of GIST, for example, then there are other treatment modalities aside from surgery, no? So you remove the lesion and then you give your patient immunotherapy, like imatinib, for example, for GIST. Okay? And of course, last in our topic is the retroperitoneum. Okay? There are three spaces there: anterior pararenal, perirenal, and your posterior pararenal, with reference, of course, to your kidneys. Okay? And what is more important is that your retroperitoneal area is very prone to infection because most of the time this is a result of hematogenous spread of infection. Huh? So it can result from infection from nearby areas, nearby organs that has access to the retroperitoneal area. Example is perforation of your retrocecal appendix, or diverticulitis in the right side of the colon, for example, because we know that your ascending colon do not have a peritoneal lining, or there is no visceral peritoneum lining the posterior wall of your ascending colon. No, so if you have a perforated diverticle in the posterior wall of your ascending colon, then the infection can spread in the retroperitoneal space. Okay, and this will present with growing pains, fever, or chills, or even erythema of the umbilicus or of the flank, no? Which is similar to what you see if you have hemorrhagic pancreatitis, no? Your Golden sign and your Gray Turner sign. Okay. So, of course, imaging is very important, and treatment would involve source control. No? If it is from a perforated diverticula or appendix, then you have to address the primary source of the infection. And then, aside from removing the primary source, you have to drain the abscess cavity and you have to resort to the use of antibiotics to control the infection. Now, once in a while, if the lesion is small, a small abscess, then you can do image-guided aspiration. Okay, so after aspiration, you have to maintain your patient on antibiotics. Sometimes you even need to place in an indwelling catheter to make sure that you are able to drain reaccumulation. So you would rather do that than repeated reaspiration. Okay? So it is very important that you address this soon enough. Otherwise, delayed diagnosis can result in high morbidity and mortality. Okay? So fibrosis can also happen. Okay? So these are the possible consequences, no? Chronic periaortitis. Usually it is associated with an immune disease. Okay. Non-specific findings